total knee arthroplasty in valgus deformity, how technology may simplify us. Presenter is Dr. Fredrich. He is online. He's already in line with us. We are slightly before. It was scheduled for 3:30 Indian Standard Time, and it is 3:15, but we will go ahead. Anand, is he online? Can we go ahead?
I'm happy to.
Yeah. Dr. Fredrich, can you hear us? Please unmute, Dr. Fredrich, please unmute. We are not able to hear you.
Oh, okay. So
yeah,
that's it.
yeah, we got it.
Can you hear me? Can you hear me now?
Yeah.
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 Can you hear me? So,
yeah, we are able to hear you.
Listen, yes, very good. In order to avoid any glitches, because we all know that computer works very well, but sometimes it doesn't. I pre-recorded my talk, and I think the team can, if they want, launch the talk, and I'd be more than happy to reply afterwards. So is the team okay to start the video that I sent? Hello, can you hear me?
Yeah, we are able to hear you, but slides we want to adjust. He's trying to adjust. Give us some moment. Yes, Dr. Fredrich, we are now able to see your slides, severe valgus knee deformity and CAS. Yeah, go ahead now.
Yeah, so is it, okay, that's the video, so you can go for it, yes, if you don't mind.
Arthroplasty center in Europe. We perform more than 4,000 joints a year. So I've been asked, working in one of the biggest arthroplasty centers, I would have loved. Hello everyone, this is a great pleasure for me to be with you today virtually, and I'd like to thank the organizing committee for inviting me, and especially Ashish and his scientific committee. I would have loved to be physically present, but I couldn't, and hopefully that will be next time. My name is Fredrich Picard, and I am orthopedic surgeon at the Golden Jubilee National Hospital, working in one of the biggest arthroplasty centers in Europe. We perform more than 4,000 joints a year. So I've been asked to talk about severe valgus deformity and computer-assisted technology that I have been using for the last 29 years. I'm sure you are all familiar with the goals we expect to reach after valgus knees, which are representing only 10% of total knee replacement. These knees require particular attention pre-op, clinically, but also radiologically, in order to define a clear strategy. The goals are actually always the same with knee replacement. We want to end up with a very stable, well-aligned, well-balanced knee in order to get our patients back on track to the early recovery and early rehabilitation as soon as possible. We expect a patient to be pain-free, with a good functional outcome and the optimal long-term survivorship implants without any complications. I'm also certain that you are all familiar with all sort of classifications in valgus knees. Some of you may use different ones. Here are a few ones you may have seen. Watt, Ludwig, Billiot, Paco. All of them are assessing actually alignment and laxity. In order to make this presentation as simple as possible, I'm going to use the one-on-one classifications. Grade 1, which represents 80% of knees with a correctable valgus and a deviation less than 10 degrees. Grade 2, 15% with an elongated MCL and values between 10 and 20 degrees. And grade 3, 5% of them with more than 20 degrees. We are going to look at the grade 2 and 3 because most of the grade 1 are actually straight forward. The questions we always ask ourselves in front of valgus knees are what sort of release we need to do in order to balance and align well our knee, and that has direct applications on not only the approach we are going to perform, but also what kind of implants we are going to use for surgery. The other questions are, do we need to start with the femoral cut first? I'm going to put in yellow what I do, which is tibial cut first. We can debate on that roughly for hours, but as some of my old teachers used to say, when you build a house, usually you start with the basement and not with the roof, and that follows this very basic principles. The second is whether we need to do a lateral release from a medial approach or the lateral approach. On a very tight and difficult contracted knee, I'd rather prefer performing a lateral approach, and I'll show you that. Third, what do we need to do? Bone measured resection technique or gap balancing or both? And finally, what about the use of conventional instrumentations or computer robotic assisted instrumentation? There is no doubt for me that computer has an excellent and even extraordinary role in our surgical performance. The first thing I do is to use the high tibial osteotomy software. I'm lucky to have been working with this software for years, and the registration is exactly the same as the one performed with total knee replacement, except that we don't open the knee. So what it means is once we have put the trackers on the femur and the tibia, then we can start the anatomical landmarks and kinematic registrations. And once this is completed, then we have an immediate feedback on the knee alignment and laxity. So here is an example. Here it goes a little bit fast because we don't have much time. The lateral compartment is very tight, the medial is very slack, but we are going to measure that using the computer technology. Then we put the trackers on the femur, on the tibia, then complete the registration, and then we can check the alignment immediately and also the correctability of the deformity. What we had for this knee, as you see here, was 20 degrees valgus with a fixed flexion contractor of 18 degrees. And during stress test measurements, you see that the valgus could only be corrected to 6 degrees. For me, this is a definite indication for lateral approach. It is always possible to perform a medial approach in case of moderate release, and it will be then possible to release the ITB, remove the osteophytes, release the posterior capsule, correct the fixed flexion contractor, or perform sometimes the C-plasty or pie crusting, which are actually not necessary for most of these knees, which are grade 1. Again, 80% of the cases, as we saw previously. If we need to perform an extensive release in grade 2 or 3, then we will need to detach the PCL, LCL, popliteus, step by step, and very exceptionally the biceps femoralis. I don't do it. Why not? Because this is the main reason of messing up with the peroneal nerve. So I don't do that because I'm using another safer technique that I will show you. The second option is to do what we call a capsule horizontal section using the Berlin technique. This is a tricky technique, so I don't really do it either because, well, especially because we are very close to the nerve, just 5 millimeters behind the capsule. However, if you have a very steady and good hands, please just do that. What I'd like to do, especially on young patients, is vertical lateral condylar sliding osteotomy derived from Cablish Breyer technique. And finally, it is always possible to pick and to use a constrained implant. The lateral approach can sort out the release and the balance in the same time. And what are the advantages? Well, the direct lateral exposure on the lateral apoplastic condyle. You have a control of the external rotation of the tibia. You can proceed for sequential release. You preserve the vascularity of the QTP mechanism. And finally, you have a direct control of the patellar tracking just in front of you. The disadvantages are that this technique is definitely more demanding, it's less routine, and there are a few tricks that I'm going to show you. So how to perform the lateral approach? The lateral approach is not a mirror image of the medial approach. There are 3 and even 4 parts in it. The first one is on the top one, and you can cut along the wide part of the VLO tendon, equivalent to the medial parapatellar approach that we would do on the VMO. But this is where the comparison with the medial approach stops. Then you have to stop on the top of the patella because you have to stay a centimeter away from the patella when cutting the lateral retinaculum. Then underneath you have to go close to the patella when releasing the synovium, all along the lateral facet of the patella. So at the end of the surgery, you'll be able to close and stitch together the retinaculum and the synovium and cover the lateral prosthesis. Then you have to pull the Hoffa ligaments and the lateral meniscus towards you in order to avoid the cutting the vascular supply that you see here on the picture from the anterior tibial artery, because if you cut that, then you may end up with a lateral necrosis of the skin just in front of the prosthesis, which is definitely not ideal. And finally, do we need to do a tibial tuberosity osteotomy? Actually, I don't do it very exceptionally. So very quick, here is a lateral approach. I just like to stitch the lateral vascular supplies. Again, it goes a little bit quick. But we don't have much time. Here is the VLO. Then you cut the retinaculum in 2 planes compared to the synovium underneath. And then you pull the fat pad towards you and detach the ITB on the girded tubercle, and you have a direct access on the lateral compartment, the lateral osteophytes. And here it is. You can even mark the white side line with your diater. So the sequences are first the tibial cut, 90 degrees to the tibial mechanical alignment, or less than 3 degrees of valgus, and around 2 or 3 degrees slope. Then you are going to measure your gaps, inflection and extension, which could be done once or twice, and then start the release process, or use a more constrained implants, and then you will perform your femoral cuts, reassess, and close. So here is an example. You have here a valgus knee. We cut to 0 with respect to the mechanical axis, 7 millimeter with respect to the medial side, so very little, and 2 degrees slopes. Then we measure the distal femoral mechanical angle. It's here 8 degrees valgus, because there is a lateral apoplastic condyle, which is quite common. Then we do have an extension 4 degrees gap with 20 degrees fixed flexion contractor, despite the ITB approach and the release on the lateral side. So we did a release of the ITB, we removed the osteophytes, we removed the menisci, and we removed the ACL. So the next step will be to release LCL, popliteus, and posterior capsule. You can do that sequentially, as well as the PCL, or you can use what I'm doing, which is epicondylectomy, or lateral femoral epicondylar osteotomy. One of the advantages of it is you have in the same times, you can detach the LCL right here, you detach the popliteus right there, and obviously the capsule inside. Here is the vertical osteotomy on the bone model. Here is on the anatomy, and you can see that the common peroneal nerve is not too far, but it is in the same direction. And this is why I'm always worried when we start to fiddle with the horizontal capsule section. Whereas when it's vertical, you can have a sliding bits of bone going down, and this is what the epicondylectomy does on the gap measurements extension. And then we need to fix temporarily this osteotomy and measure the gap inflection. So here is, let me show you a very short video. You can see here there is a lateral hypoplastic condyle. The Roman is put in the back. The second one is put in the back. And then that's it. The cut is done. I perform the extension gap, flexion gap. You can see the lateral condyle fixed. And then I can assess my femoral cuts. The distal cut is performed. You still see very well the osteotomy on the screen. The rotation is done, and finally we can complete the femoral preparation, removing all the osteophytes in the back, in the middle, keeping the PCL. This is a cruciate retaining knee here. And finally, it is therefore possible to assess the knee with the tibial tray that I'm going to slide right here. I can remove now the pins on the tibia because the flexion gap is correct, and we can assess the knee. And you can see the knee is stable, excellent tracking, good flexion. no issues in flexion and extension. So that was the final slides for our assessment. You can see we use a size 5. These we had cut 3 proximals to the femur, and then we had a gap between the 3 and 4 inflection with a rotation of 6 degrees, which was absolutely fine. And then at the end of the assessment, that's what we had, a knee with 2 degrees valgus, with a slight fixed flexion contracture of 3 degrees, which is absolutely fine. And that's the knee after surgery, and you see the screws on the lateral side of the condyle. Because it's very stable, the prosthesis covered the cement, we don't need to use most of the time any brace of any sort. So the take-home message is when you have a contractured knee inflection and an extension, you have to assess whether it is related to the ligaments or the muscles, obviously, and then the computer can definitely help measuring and assessing the laxity and your overall alignment. You can check the patella and the tibial position, which is also extremely important to assess using the technology. Always cut minimal on the tibia first, with the meticulous lateral approach. If you do it using special medial retractor, especially on the medial side, and you can leave the knee with a possible slight residual valgus around 5 degrees. Computer-assisted technology helps to measure step by step your knee replacements. So here are a few references and some others more recent, and I thank you very much for your attention, and I'm happy to take any questions.
Thank you very much, Dr. Fredrich. This was a...
Hello everyone, this is a great pleasure for me to be with you today virtually, and I'd like to thank the organizing committee for inviting me, and especially Ashish and his scientific committee. I would have loved to be physically present, but I couldn't, and hopefully...
Any questions from the house? Dr. Fredrich?
Yes.
Are you, in your this case, you went through the lateral approach. Suppose there is some planning, misplanning initially, and somebody enters through the medial approach, how he can rectify whatever he has entered already in the joint, and he is having all the problems in the lateral compartment, what all he can do?
Well, that's a good question. Obviously, when you perform a medial approach, and this is quite common, I would say, all over the planet to perform a medial approach, even with a valgus knee, and then to go step by step release. And I'm sure you have, most of the surgeons in the room have done that, starting by releasing the PCL, and then releasing the LCL, and then releasing the popliteus, and then even a little bit more the capsule, and then you have access to the posterior osteophyte. So most of the time, I must admit that it is potentially possible to do such a release, and then open the lateral compartment, because that's what you want. One of the issues I have with this is sometimes the release is so big that you end up with a lateral laxity, because obviously you don't have anything keeping the lateral compartment stable. So this is why I put in this talk, for example, the use of more constrained implant, And I'm sure the safe side would be when you end up with such a degree of laxity, is probably to use a more constrained implant, which could be, for example, a TS implant, or if your valgus knees is greater than 20 degrees, and I'm sure you have seen some of this massive, valgus with 30 degrees, then some literature are recommending to perform, a hinged knee straight away. I'm not so keen to do this for younger patients, but I would think that it is a safe place to go for older patients. So to answer your question, if you do a medial approach and you want to balance your knee in valgus, it is safe to go step by step. So if you use the computer, you can see and measure your correction angles. And if you don't, then it is you're going to have to use spacers just to see you have a right balance between the medial and the lateral compartment. That would be my answer to that.
Dr. Fredrich, in the severe valgus knees that you have encountered, have you ever thought of changing the rotation of the femoral component, especially when you are using navigation? Sometimes there have been occasions in which you have to sometimes internally rotate the femur, or have you ever encountered such changes in the rotation of the femoral component, especially dealing with severe valgus knees?
Yeah, well, it's a very good question. Thank you very much. As you know, most of the severe valgus, grade 2 or 3, they do have lateral hypoplastic condyles. And so what it means is the middle condyle is big, whereas the lateral condyle is small. And that explains also usually the association with patellar maltracking. So when you compare the posterior condylar axis to the white side line, and that's the white side line I marked in this video with a W, because we can see very well the osteophytes always on the knee. You have clearly a very severely internally rotated posterior condylar axis compared to the white side line or the transepicondylar axis. So yes, we need to modify the rotation. And that is true that, for example, for a valgus knee, if you use the conventional instrumentation and you only turn the femoral components by, let's say, 3 or 4 degrees, or even, let's say 3 or 4 degrees, which is the recommendation, then the knee will still be in internal rotation compared to the transepicondylar axis, and then you keep a very large gap on the lateral compartment, which can generate instability in flexion. So this is why the rotation has to be adjusted with respect to the white side line, with respect to the transepicondylar axis, and with respect to the gaps. And this is why the computer is very useful, but if you don't use it, you have to use a spacer just to make sure you have very good gaps. Prof. Ranawat always says that it is extremely important to have a very good gap flexion in these knees, and the rotation of the femurs that is obviously crucial for that.
Thank you very much. Really enjoyed your talk, and hopefully we will be meeting soon in some other forum. Thank you very much from this side, from India. Now we are moving towards the next topic. Dr. Sudeep, professor in orthopedics at All India Institute of Medical Sciences, he was talking on the severe varus knee.